This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1.
Extract 1. Questions 1 to 12. You hear a gastroenterologist talking to a patient called Simon Mortlake. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Now, Mr. Mortlake, I think you've been referred by your GP. I've got your notes here, but perhaps you can tell me in your own words what seems to be the problem. What's brought you here today?
Sure. Well, it's not the first time I've been to this clinic. I was referred to one of your colleagues about 3 years ago. I had what I thought was a stomach ulcer, which had been troubling me for some time, and my GP suggested I came in for tests. And I had what he called an endoscopy. You know, where they put a tube down your throat and have a look at your insides. And as part of that, they also did a biopsy to make sure it wasn't something more serious.
That's right, and that was clear.
Yes, it was, fortunately. I actually had a condition called Helicobacter pylori, and I went on a course of tablets for that.
Right.
It was cleared up in no time, very straightforward. But the consultant did say that I needed to be alert for any further symptoms. You know, that there's a greater risk of cancer developing after you've had that, and that I should come straight back if I had any problems.
Oh, indeed. And have you had any other medical problems since then?
Well, a couple of years back I had a hernia operation. That was also very straightforward. I had that done just after I retired. I expect it was actually an occupational injury of some kind because quite a few of my colleagues have had similar problems.
Okay.
I was a police officer for most of my working life. Other than that, I keep relatively fit. I'm not taking any medication for anything. I've been well until just recently.
Okay. So what's happened to change that?
Well, I've started to suffer from indigestion, particularly after lunch or dinner. I get heartburn, you know, pain just here.
I see. And are there any other symptoms?
Well, I've also found myself running out of energy. I'm a keen gardener, and I'll be digging or whatever, and suddenly I feel a need to take a rest. I mean, that's not like me. I usually want to finish a job once I've started it, you know. But if I try to push myself too much, I start to get breathless, and that's a bit worrying, to be honest.
I see. And are you aware of your weight changing at all?
Not really. But what I have noticed is that I just don't seem to have such a good appetite anymore.
Right.
I mean, that's partly being retired, I'm sure, but I do keep pretty active. It's just that I don't fancy the sort of big meals I used to eat. I start to feel sick if I have too much.
And are there any other pains or physical symptoms?
Not really. I've been looking out for things like my stomach swelling up, because I know that might be a symptom of something. But to be honest, I can't say I've ever had that.
So what do you think might be the problem?
Well, the thing is, my uncle, that's my mum's brother, he had to have a gastrectomy. And I remember this is how it all started. I mean, the symptoms I've described, and, well, I think these things can run in families, can't they?
Well, they can.
Anyway, the real reason that I want to get checked out is because I've got a big trip coming up. The wife and I have booked tickets on a cruise to Antarctica. I mean, it's the trip of a lifetime. We're really excited about it, but I need to make sure I'm well.
Okay, well, I understand your concern. So what I need to...
Extract 2. Questions 13 to 24. You hear a vascular surgeon talking to a new patient called Monica Patterson. The questions 13 to 24 complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Patterson. Your GP has sent you to see me because of some problems with your legs, is that right?
Yes, varicose veins, and they've just been getting worse and worse.
Right. Well, I've got some notes here from your GP, but I wonder if you could tell me in your own words when this started and what's happened so far.
Well, I guess the first time I had problems with my legs was ages ago, when I was pregnant. My son's 25 now, so that shows you how long ago it was. But everyone knows that varicose veins goes with that, don't they? They look horrible at the time, but then they usually disappear again.
And was that the case?
Well, by about a year or 18 months later, they'd gone completely. My legs were looking and feeling fine, and I was back at work then too.
Uh-huh. What do you do?
I was a chef in quite a busy restaurant, so there wasn't much opportunity for sitting around in that job, Doctor, I can tell you. But then, it must be getting on for 4 years ago now. I noticed the veins were coming back. At first I wasn't too concerned, although they seemed to get very scaly, and they itched too around the calves. I tried to follow the advice you find on websites. You know, move around at work, try to keep your feet up on a stool, and avoid crossing your legs.
Mm-hmm.
And I did insist on getting a bit of exercise every day. I always managed to fit in walking around town after the lunch service, just for about half an hour or so.
Good. And what treatments have you had so far, Mrs. Patterson?
I first went to see my GP just because they looked ghastly, and I was a bit worried about them. But he said that he could only recommend proper treatment when they got worse and were painful or I had any complications. But he did tell me I should lose some weight. That's an occupational hazard in my job.
Good advice, though.
Well, I did manage to get it down a bit. Anyway, about a year ago, my left leg really swelled up. In fact, they both look pretty nasty with the bulging veins. And you can see now, my feet and ankles are really swollen up.
Yeah.
Also, when I'm in bed, I regularly wake up with terrible cramps. Last night, I didn't know where to put myself. So, then the doctor did an ultrasound scan to see if there was a blood clot. Thankfully, that was all clear. but we agreed it was time to get my legs sorted.
Yeah.
The doctor arranged for me to have some injections of foam in the veins. He said it was quite a new treatment. It was just with a local anaesthetic and I didn't have to stay in overnight, which was good. I had to wear bandages afterwards for a week or so, and then those compression stockings for another week.
And since then?
Well, that seemed to do the trick at first. They felt much better to start with, although I had awful headaches for the first few days, which I gather happens sometimes. Anyway, now they really seem to be worse than ever, so I'm back to square one. I'm thinking that either we have another go with the injections, or maybe I need to consider surgery this time. That's obviously more invasive, and I know from other people that I'd be very sore afterwards and would have to take time off work. That's a consideration too. I run my own hotel now, so I can't just close it for weeks on end, can I? So, what do you suggest now, Doctor?
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a nurse on an obstetrics ward talking to an obstetrician. Now read the question.
Excuse me, Doctor, could I have a word about a patient?
Sure.
In room 12, we have Mrs. Tate. She's a 35-year-old G3P3 woman who came in yesterday complaining of breast tenderness, bloating and mild nausea. Her last menstrual period was 6 weeks ago. She's married with 3 children under 5 and uses contraceptive pills for birth control. On physical examination, she is afebrile with a heart rate of 90 and blood pressure of 140/80. The urine pregnancy test has resulted positive, and transvaginal ultrasound reveals a 6-week sized gestational sac with detectable fetal heartbeat. What's concerning me is that she's visibly distressed. The pregnancy was unplanned and she's anxious about the emotional and financial implications. She was on bed rest for 6 weeks during her last pregnancy and she's aware of the risks and difficulties of carrying this one to term. Would you be able to speak to her?
Question 26. You hear a senior doctor giving a group of medical students training in how to conduct a physical examination. Now read the question.
Today, I'm going to be demonstrating how to examine a patient's shoulder. So, you've taken a full history, which means you've got a fairly good idea what it is you're looking for, and it's time for the physical examination. Now, the thing to bear in mind is that the shoulder's an extremely complex joint, and there are many specific tests we can apply during an examination. Therefore, it's best not to jump to too many conclusions about the diagnosis. If you just go looking for that one thing, then you risk missing something else that might be there. So, how to conduct the examination? Well, you need to be organised and follow a set routine. The first thing is to ask your patient to remove their shirt or whatever to expose the area you're examining. Watching the patient do this is often quite instructive with shoulder problems because you can pick up whether they're actually guarding the shoulder as they do that. And that might give a clue as to the possible nature of the pain or exactly where it's located.
Question 27. You hear a GP talking to a patient about his mother. Now read the question.
So, how can I help you today?
I've come about my mum, actually. You know you referred her to the memory clinic.
Yes, that's right.
Well, the thing is, she went there and she's been diagnosed with Alzheimer's. I guess we should have known what was coming, but it still comes as a bit of a bolt out of the blue, to be honest.
Oh, yes, I'm sure it has.
Well, Mum seems to be okay with it. It's me, really. I mean, I know what Alzheimer's is, but I don't know that much about it, really. So I thought it'd be best to come and see what I ought to be doing. My mum lives on her own at the moment, and she's coping fine, but how long's that going to be the case? Is there anything I should be doing? You know, is it going to get worse? I mean, do I need to start putting things in place to help her, or is that just going to alarm her? Is she safe to look after herself? Should I be looking out for certain signs or anything?
Okay, look, I understand your concerns. Before we go any further, though...
Question 28. You hear two nurses discussing a patient's care plan. Now read the question.
Shall we go over her care plan next?
Sure.
I'd say that the priority is some Lovenox training because she's likely to be going home on that. She's been having a little bit of anxiety over this current hospitalisation and the recurrence of her condition after a period of remission. She's a high fall risk and she's also been in acute pain, but that's been well managed, so it's more about the anxiety.
Did you have to give anything for that?
She was okay without any pharmacological intervention, actually. We've been doing breathing exercises, and they're going well.
Okay. Anything else that we should be seeing to?
If she can show us that she's able to handle the injections, then we can go ahead and move to sign-off.
Okay.
Question 29. You hear a surgeon briefing his team before an operation. Now read the question.
I think this patient could be quite a problem post-operatively. Is he taking oral medications?
Yes, he's on phenytoin.
OK, so if his gastrointestinal tract becomes unusable, we need to be ready to deliver that intravenously. The other issue with him is that from his records I can see that he's actually had quite a bad time in the post-operative period on previous occasions. He was a heavy smoker, but claims to have cut down considerably. Even so, he's going to have a larger midline incision, so he may be someone that you want to consider for an epidural, because he's likely to be at the extreme edge of the pain threshold.
We'll see at the beginning with the wound catheters and PCA. If necessary, we can do the epidural in the recovery room if he's in difficulty.
Fine.
Question 30. You will hear a dentist talking to a patient. Now read the question.
So we're going to fit your implant today. Have you had any problems since your last appointment?
Well, there was just one thing. You remember how hard you had to pull to get the impression off of my teeth once it had set?
Yes, it is a very tenacious material.
Well, the next day, one of my crowns dropped out. Look, I've got it here. Do you think that was what caused it to happen?
Oh dear, I'm sorry about that. I can probably refix it for you today if you want. These things do happen sometimes, I'm afraid.
Oh, thank you. That'd be great. But actually, what I was wondering was if I might have an implant instead of that crown as well. I mean, it's the second time it's fallen out, actually. I've had it years.
Oh, well, in that case, let's have a quick look at the tooth itself and see what might be possible.
Thanks.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Extract 1. Questions 31 to 36. You will hear an interview with a sports injury specialist called Toby Walsh on the subject of hamstring injuries. You now have 90 seconds to read questions 31 to 36.
My guest today is a sports injury specialist called Toby Walsh. We're going to be talking about hamstring injuries. Toby, hamstring injuries are something sports people at all levels of ability fear getting. Why is this?
Well, you're right. Hamstrings are the most significant injury in a number of team sports, including football and rugby, but any sports person could be affected. I think, looking at the statistics, hamstring injuries account for the largest number of lost playing hours amongst professional footballers, even though the average injury only takes about 3 weeks to heal. More worrying for the individual is that once they've had such an injury, the chance of sustaining another one in the same season is as high as 20%, so it can become the thorn in the player's side. That, I think, accounts for the reputation the injury has.
So is this an injury that can affect any of us at any time?
Well, the hamstrings are a group of muscles in the thigh that allow us to bend our legs and knees effectively. Now, some ethnic groups are more predisposed to these injuries than others, and everyone's chance of tearing the muscle increases with age. But apart from that, they're generally the result of short bursts of movement, like sprinting or suddenly changing direction, and they happen more in certain sports because these are just the sort of movements that players are making. They happen most often at the end of what we call the swing phase of running, just before the outstretched leg hits the ground and the muscles contract to bend the knee.
But I'm sure there are ways to prevent these injuries.
Well, looking after the muscles themselves obviously helps here. You can do various exercises that actually strengthen the hamstrings and so make them less prone to injury. And of course, warming up before exercise is crucial in avoiding all sorts of muscle strains, and sports people know that. But that isn't the whole story. One interesting finding is that a lot of people who develop hamstring injuries have coexisting back problems, and there would seem to be a correlation. By loosening up the lower back, you also help the nerves that control the hamstring. Flexibility there allows the muscles to function as they should, and there are exercises people can do to help that.
And is the risk of hamstring injury something that should be taken into account in training programmes?
Well, yes. Intensive training, of the sort you do for team sports like football, can put quite a heavy workload on the gluteal muscles, which can lead to a tightening around the hips, creating knots known as trigger points. These, in turn, can cause referred pain in the hamstring, reducing flexibility and increasing the risk of straining or tearing it. I mean, basic stretching exercises can help here, but also we know that muscles are more likely to strain if they're fatigued. Often, during a period of intensive training, you get cumulative fatigue. This can creep up on an athlete, on their muscular system over a number of weeks as the training intensifies.
And if an athlete does pull a hamstring, how can the sports injury specialist help?
Well, they'll feel the pain, maybe even feel a pop, and they won't be able to continue because the muscle will go into cramp and spasm. There are 3 degrees of severity, and the treatment will vary according to that. Fortunately, as a sports injury specialist, you're often present when the injury occurs, or you can see it on video, so you don't have to rely on a verbal account of symptoms to assess the severity. Initially, you want to stop any swelling as soon as possible. That's your priority. You're going to apply compression bandages and possibly ice. Although there's some debate about that these days, it does ease the discomfort. And you'll certainly elevate the leg and make sure the patient rests up.
And how long will the athlete be out of action?
Well, as I say, that's going to depend on the severity of the injury. They'll have to rest up for 72 hours, whatever happens, to avoid causing further damage. And things like heat and massage can be just as damaging as movement itself. A grade 3 injury can take months to heal and can be career-threatening for top athletes. What's more, lack of use can lead to the development of scar tissue and muscle shrinkage. In other words, the muscles won't return to their former state, even if the tear or strain itself heals. So part of my job is to ensure that doesn't happen by getting the muscles working again in the right way as soon as possible.
Now look at extract 2. Extract 2. Questions 37 to 42. You will hear a clinical pharmacist called Emma Royce giving a presentation about the side effects of certain types of medication. You now have 90 seconds to read questions 37 to 42.
My name's Emma Royce, and today I'd like to talk about some unanticipated side effects of certain widely used medications. The side effects that I'm particularly interested in involves changes in a patient's behaviour. In particular, the onset of what's known as compulsive or pathological gambling in patients suffering from Parkinson's disease. Pathological gambling is essentially an addictive disorder in which the patient feels a need to engage in financial risk-taking in the expectation of gaining a reward. It is characterized by both recurrent and persistent behaviors and can lead to significant distress and the breakup of personal relationships. The condition is thought to affect around 1.4% of the general population, a figure which rises to 7% in Parkinson's patients. It was this finding that led to the realization that there was a link between the medication prescribed for that condition, notably dopamine agonists, and the onset of pathological gambling. So, how common is this side effect of Parkinson's medication? On the surface, it would seem that it remains the exception rather than the rule, only affecting around 1 in 7 users, and not all of those in a severe way. Also, because only a small proportion of patients treated with dopamine agonists develop the symptoms, it may reflect specific predisposing factors. The exact level of incidence is unknown, however, and this may be because many cases go unreported. Patients themselves or family members don't admit to the condition out of shame, or because their doctors or carers haven't been able to identify it. And this could explain why it doesn't show up more frequently in pharmacovigilance reporting systems. Let me give you an example of a typical case. A 74-year-old male, let's call him Harry, who was diagnosed with Parkinson's disease and prescribed the dopamine agonist pramipexole. About a month after commencing treatment, he began to feel an increasing need to play slot machines until he was going to a gambling venue every day. At first, Harry was able to conceal his behaviour from family members, another common feature of the condition. His wife did notice other symptoms. Harry was having difficulty sleeping and wasn't finishing his meals, but she put these down to his Parkinson's. It was when Harry began impulsively buying items that he neither needed or wanted that his wife became alarmed. It was at this point that the hole in his bank balance caused by the gambling came to light, and the couple was able to seek help. In other cases, heightened sexual activity has been identified as an indicator. There are several underlying risk factors for developing pathological gambling: male gender, a previous or family history of gambling, personality traits such as high impulsivity and high novelty seeking. The risk increases when such people take dopamine agonists as treatment for Parkinson's disease. Originally, research suggested that the higher the dose and the longer the duration of the prescription, the greater the likelihood of compulsive symptoms occurring. More recently, however, research into the use of the medication for another condition, restless legs syndrome, or RLS, has shown that symptoms can develop even at low doses. So, what are the long-term effects of these adverse reactions? Pathological gambling seems to be reversible when the dose of the dopamine agonist is reduced, or the patient is transitioned to an alternative medication. Basically, dopamine agonists help Parkinson's patients by replacing the loss of dopamine in areas of the brain that control the ability to move. But the increased dopamine levels then affect other areas, such as the neural system linked to pleasure and reward behaviors and associated emotions, which then manifest themselves as impulsive and compulsive actions. But the effects are not long-lasting. Harry lost all interest in gambling within a month of stopping pramipexole therapy. But sadly, for many patients, the problem isn't picked up before life-changing disruption is caused, as significant gambling debts develop and relationships become strained. So, what can we do to improve the management of these side effects? There's no doubt that Parkinson's is a serious and degenerative disease, so the drugs may represent a reasonable trade-off in terms of risk-benefit analysis. It's hoped that by educating patients and carers about potential side effects, it'll make them more willing to report changes of behaviour. Patients and their carers should be monitored closely for the symptoms, so that as soon as any side effects do emerge, the drugs can be tapered or discontinued. For other conditions, such as RLS, however, it is open to debate whether the risks associated with compulsive behaviours outweigh the therapeutic advantages of administering the medication. What is needed is further research to establish just how extensive the problem is.
That is the end of Part C. You now have 2 minutes to check your answers.
you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12.
You will hear Dr. John Hope interviewing Brian Brown, who has come seeking treatment for a current problem.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning. Come on in, Brian, and tell me, how can I help you?
Oh, hello, Doctor. Look, I've come here because I've got a real issue with sleeping, and I was hoping you'd be able to prescribe with them sleeping tablets.
Well, just before we go straight into a prescription for tablets, I think it would be useful if you could just tell me a little bit more about your problem.
Okay, well, it relates to my work. I work at BP Oil Refinery, and I do a lot of shift work, and because of that, I've got irregular sleeping hours, and I'm not sleeping well at all.
And how long has this problem been going on?
Well, I've been working at the refinery for about 3 months now.
Mm-hmm.
And I started night shift about 6 weeks ago, and it's been building up since then.
And tell me more about your work hours.
Well, basically we do 12-hour shifts in the daytime, and that's followed by 2 12-hour shifts in the night time.
And is this problem sleeping after the night shift, or is it no matter whether it's day or night?
Actually, I can sleep after the day shift, but after the night shifts I'm having a lot of trouble. I don't seem to be able to get more than 4 or 5 hours sleep after the night shifts.
Oh, that's no good. And how does this impact on your work?
Well, it's a problem because, my job's quite dangerous and we need to monitor a lot of equipment and operate some machinery.
Mm-hmm.
And I'm finding that I need to be alert, and when I'm tired, I have to resort to drinking a lot of coffee and lots of caffeinated drinks just to get through my shifts.
Right. Well, Brian, would you mind if I just went through and talked about what things we can do to help you sleep better? Because I think it's important that we do more than just prescriptive sleeping tablets.
Okay, I guess so.
Generally speaking, sleeping tablets are of short-term use only. What happens is that if we start you off taking sleeping tablets regularly, you're going to find over time you have to increase the dosage to get any real effect, and there's a real risk that you'll become dependent on them.
Well, look, I don't really care too much about that. It's now that I'm having trouble. What's important to me is that, I keep my job. You know what happened to me on my last shift? I actually fell asleep for 15 minutes and my supervisor caught me out there, and it was due to not getting enough sleep. So that's really why I've come here today.
Well, we'll go on to look about what we can do to help you over this immediate problem. But I'd like you to realise that with sleeping tablets, it's not only the fact that you may become addicted to them, but that it can actually impair your memory and your ability for critical thinking.
Really?
Now, you were telling me that you're working in quite a dangerous profession, and it's really important that you're alert, that you're not suffering a hangover from sleeping tablets.
Right, I guess I see what you're saying.
Now, Brian, I'd like to talk to you about what living environment is like, what your living environment is like. Where do you go to sleep normally? What sorts of things would make it difficult for you to get to sleep?
Well, the noise in the daytime, I suppose. There is a lot. We live in the suburbs, and if it's not one thing, then it's another. For example, a neighbour might start mowing the lawn in the daytime. We've got a lot of birds that wake me up. A lot of crows at the moment. They seem to hang around the house. Sometimes the phone rings. Even the brightness of the room, doctor, or the hot weather. All of these things have been disturbing me.
Extract 2. Questions 13 to 24.
In this part of the test, you will hear Nurse Melissa Sweet interviewing Mr. Jim Fisher, an elderly patient.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Firstly, let's look at the immediate needs you'll have when you go home. Now, at this hospital, we are a very good relationship with an organisation called Blue Care. Have you heard of Blue Care?
No.
Well, Blue Care is a church-based organisation which offers a variety of community services, and they aim at maximising the individual's independence and quality of life. Their staff includes nurses who can help you with some of your personal care like showering and shaving. They'll come every second day to check on your wound. What they will do is dress your wound, apply ointment, and help you with other medications.
But what about the cost? Because I'm on a pension, you know.
The good news is that these services are subsidised by the government, so there's no charge, and no one is excluded from receiving a service because of financial hardship. They also provide a range of other services, including social support, such as a chaplain for spiritual support, who can visit you if you would like that. And they also have volunteers who can call in for a chat if you want some company.
Yeah, well, I can see that would be a help.
Now let me ask you how you see your future. Do you want to continue to manage in your own home, or would you prefer to move to an aged care facility?
Oh, no, I want to stay in my own home. I'm just worried because I'm still recovering from this wound and I don't know how I'll manage to cook.
Let's just take this one step at a time. I can also arrange for an organisation called Meals on Wheels to bring in your meals.
Well, that sounds okay, but how does that work?
Well, they generally come in daily, 5 days a week. They provide one main meal per day, which is healthy and nutritious.
What about Saturday and Sunday?
Well, on Fridays, they provide extra meals for the weekend, which you can keep in the fridge. Now, for the longer term, we'll arrange for the aged care assessment team to make an appointment for a visit for you. Have you heard of this service?
No, I haven't.
The government has provided this service because they want to help and encourage you to continue to live in your own home as long as you are capable of managing.
I see.
The team, which might include a doctor, nurse, social worker, or other health professionals, come to your home and assess what your needs are and how you're managing. They assess your ability to manage on your own at home.
Well, as I said before, I'd like to stay at home. I've still got all my faculties, but I don't think my balance is all that good. So what would happen if I had a fall and no one was there?
Well, Mr. Fisher, do you have a safety rail in your shower?
No, I don't.
Well, you see, they can arrange for safety modifications like support rails in the bathroom and toilet, or safety ramps where they're needed.
Well, that's good because, you know, it's a 2-storey house and I worry that I could have a fall on the steps.
Well, adequate support rails would be a consideration to make you feel safer. They can also organise a medical alert bracelet.
How does that work?
Well, this can be worn on your wrist. In an emergency, you press the button and a message is sent to the ambulance service who will respond quickly.
Yeah, well, I didn't really know there was all that help out there.
Now, I'll give you this set of brochures which tells you all about the services offered by Blue Care, Meals on Wheels and the Aged Care Assessment Team. And when you've had time to look through them, I'll call back to see if you have any more questions.
Nurse, there's just one more thing that I'd like to talk to you about.
What's that, Mr. Fisher?
Well, as I said before, my old neighbours have moved away and our neighbourhood's changed a lot. So I do feel a bit alone, you know, and over the past year there's been several house break-ins in the neighbourhood.
Well, there is one other thing I could suggest.
Oh, well, what's that?
It's another government initiative called Home Assist Secure. And if you're over 60, which of course you are, you can receive advice and help relating to home safety issues.
Oh, what can they do?
The Home Assist field staff have been trained and cleared by the police to come to your home and offer you free information and assistance.
What kind of assistance?
Well, they can help you with security lighting outside your home. They can also install windows and door locks and security screens.
Well, that sounds like a good service.
And smoke alarms are another safety device that they can install in case of a fire.
Well, that's important.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Professor Roland Stalker heads the Vascular Biology Division at the Victor Chang Cardiac Research Institute in Sydney.
Now read the question.
Okay. So, Norman, what we found is that the enzyme in our body that produces bleach, its name is myeloperoxidase. We've known for many years that this is present in coronary lesions that have ruptured.
So let's back up a bit. We produce bleach in our bodies.
That's right. We produce bleach as part of our immune response to kill bacteria and other pathogens.
So the way is we squirt it around our toilet, it gets squirted around our body to kill pathogens.
That's right,
too.
and we have professional enzymes that produce bleach, yeah.
Okay, and the enzyme that manufactures it, if you like, is called myeloperoxidase.
That's right, and this enzyme we have known for a long time is present in coronary arteries that have ruptured and have caused a fatal heart attack. What we haven't really been able to do is to establish a cause and effect relationship between the presence of this bleach-producing enzyme and a plaque rupture.
So what did you do?
So what we have been able to do.
Question 26.
Rebecca Lim is at the Hudson Institute of Medical Research at Monash University.
Now read the question.
Bronchopulmonary dysplasia.
Possibly not stem cells as a broader sense of the word, but what we think is happening is really the placenta with the amniotic sac that surrounds the baby during the course of pregnancy. We know that the human amnion has had, for well over a century now, amazing wound healing effects. So
really?
Oh yeah, absolutely. So
Give me
if you
an
go
example.
back. Yeah, so in 1910, it was a paper that I found trawling through. Do you remember what a library is?
No, sounds familiar. Sounds familiar.
So I remember presenting this to a group of medical students because they...
Who'd never heard of a library before.
Who have never been in the university library, I don't think. So I did a little scan of this article that I found, and it was from 1910. So the use of the human amnion as a biological bandage. And then if you fast forward 100 years, there are still randomized control trial data out there showing that the human amnion is actually far superior to traditional bandages when it comes to wound care for third-degree burns and for skin grafts.
So what's in it? What's in the membrane?
Question 26.
Ewan McPhee is a national leader in rural general practice. He lives and works in Emerald in Queensland.
Now read the question.
My health record.
Well, look, the My Health record in my practice is just, I guess, part of doing normal business, Norman. It's essentially an extension of my clinical record. So with a lot of my patients, I spend a lot of time making sure that my records are accurate, my medication lists are accurate, and your allergies and immunisations. Now, if you take, for example, one of my patients today, she's an elderly lady with multiple medical problems, and look, she pops in and out of hospital a lot. And it's important that, I have an up-to-date summary of what's happening with her, what her medications are, and her results. The results in my practice are available if she ends up in hospital. And she came back from a sudden admission the other day. Basically, she came in without any information from the hospital, but because the My Health record's linked into the Queensland Health System, I actually had the discharge summary there with her medication changes available to me when she came in. So I was able to basically make changes and keep a point of truth for that patient around her health. And, that My Health record has become for her.
Question 28. You hear.
The lead author was Lee Hooper, who's on Skype from Norwich Medical School in the UK. Welcome to the Health Report, Lee.
Now read the question.
So we were interested in the heart and the vascular effects. So we were interested in heart attacks and stroke and the sort of combined outcomes around whether we have events or any kind of cardiovascular event, any kind of heart event, and whether we survive them, but also all-cause mortality. So we were looking at death as well and whether they make us fatter and our lipids. So we looked at a whole range of outcomes that we felt were important around omega-3 fats.
So before we get to the heart findings, do they make us fatter?
No.
Well, that's good news at least.
We usually take them in relatively small quantities, so there's not. But they don't make us thinner, but they don't make us fatter either. So we're okay on that one.
So what did you find?
So, I mean, primarily we were interested in the actual heart and vascular effects. And basically what we found was they're not harmful, but they're not beneficial either. We see almost no effects. And we had a huge amount of information in the review. There was, as you said, 79 trials. We had over 112,000 people involved in those trials. And all of the people were involved for at least a year.
Question 29. You hear...
Peter Rothwell is Professor of Neurology at the University of Oxford.
Now read the question.
Okay.
Well, there have been a few strange observations over the years. So, for example, people had found that in the trials of aspirin, low-dose aspirin, that it seemed to prevent stroke very effectively in women, but not in men, whereas the old trials of high doses of aspirin seemed to work in men, but not women. And so one obvious possible explanation for that was it's just that it's due to body size, and that higher doses were needed for larger body size, i.e. men, but lower doses might be effective at lower body size. And so that was one of the clues to just look by body weight and obesity and lean body mass, just to see whether the effect did vary.
And you brought together the available studies.
Question 30. You hear
Associate Professor Lucinda Burns of the National Drug and Alcohol Research Centre.
Now read the question.
So when you drink alcohol, when you drink a lot of alcohol on a quite frequent basis, we can see the fetal alcohol, which, as you say, is the facial expression of various behavioural things and shortness of the child and other abnormalities. But with cannabis, we don't see those particular visual things, but we do know that there seems to be some behavioural issues that are shown. And the issue then again is, as I mentioned previously, is it is complicated by the other things that go on in the lives of women. So, for example, if they're not eating well and they're drinking, if they might be drinking, they're smoking, it's very hard to tease out the actual effects of the cannabis.
Because I think some of the research suggests behavioural issues, developmental issues, and if they're exposed to cannabis later on, these same children can have compound side effects from tetrahydrocannabinol. But you're arguing that they're so impure, these studies, you just can't tell.
That's exactly right. And these are exactly the same.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
In this part of the test, you will hear a lecture based on the subject of chronic obstructive pulmonary disease.
You now have 90 seconds to read questions 31 to 36.
Chronic obstructive pulmonary disease, COPD, is a growing global epidemic that is significant in both developed and developing countries. Morbidity and mortality from COPD will rise as populations age. Furthermore, as the mortality from cardiovascular and infectious diseases falls, the occurrence of COPD will become more common in society. This is supported by the current trend, which indicates that more people are dying from COPD each year. In addition, COPD is associated with several other diseases such as osteoporosis, diabetes, glaucoma, and sleep disorders. In Australia, almost 1 in 5 people over 40 have COPD, and it's the 4th most common cause of death in men and the 6th most common cause of death in women. Smokers, or past smokers, are those who are at major risk of getting COPD, and most people with COPD have smoked at least 10 to 20 cigarettes per day for 20 or more years before experiencing any symptoms. As a result, COPD is typically not diagnosed until the 5th decade of life, meaning in people aged 40 to 49 years. So who can get COPD? Well, whereas cigarette smoking is the commonest form of COPD in developed countries, it's also seen in non-smokers, particularly in developing countries, which may be due to the other causes of COPD, which include occupational dust and fume exposure, exposure to outdoor and indoor air pollution, including tobacco smoke, poorly ventilated living environments where pollution is present, often due to the use of solid fuels for cooking and heating, individuals who have a genetic predisposition to COPD, or individuals with a history of recurrent childhood respiratory infections. In addition, some people with COPD have worked or lived in places that were very dusty or smoky for many years. COPD is primarily characterised by the presence of airflow limitation resulting from inflammation and remodelling of small airways, and is often associated with emphysema. The common symptoms are repeated coughing, feeling puffed or shortness of breath when doing things like climbing stairs, walking up a hill, or even having a shower. a build-up of phlegm in the lungs, or chest tightness. With COPD, your lungs become larger than normal, so the breathing muscles around the outside of the lungs, such as the diaphragm and chest wall muscles, become stretched and have to work harder. This means that there's more effort involved in breathing, and it makes you feel breathless. It's increasingly recognised that COPD extends beyond the lung and that many patients have several systemic manifestations that can further reduce quality of life. So how is COPD diagnosed? COPD is tested with a simple breathing test using a spirometer, which records the amount of and the rate of air that you breathe in and out over a period of time. It's essential the procedure is carefully and clearly explained and to actively motivate the patient to perform at their maximum level. The volume and flow parameters measured are defined in terms of maximum effort and maximum exhaled volume. It's preferable for the patient to sit upright in a chair, as this is the most stable position should the patient experience dizziness during the test. The key steps are as follows. First, breathe in fully and the lungs must be absolutely full. Seal the lips around the mouthpiece and blast the air out as fast and as far as possible until the lungs are completely empty. Repeat the test until 3 acceptable results are obtained, up to a maximum of 8 efforts. The results can measure the presence and severity of COPD. The severity of COPD is categorised into 3 levels. Mild, where the breathing capacity is 60 to 80% of normal. Sufferers feel a little out of breath if they work hard or walk rapidly, especially on hills and stairs. Moderate, where breathing capacity is 40 to 60% of normal. Sufferers feel out of breath if they walk rapidly and they may have trouble doing physical activities. Severe, where breathing capacity is less than 40% of normal. Sufferers probably can't work or do household chores and have difficulty in walking upstairs or across the room.
Now look at Extract 2. Extract 2, questions 37 to 42.
In this part of the test, you will hear a lecture based on the subject of migraines.
You now have 90 seconds to read questions 37 to 42.
The word migraine is derived from the Greek word meaning pain in half the head, as migraine often produces a unilateral or one-sided headache. It is a common and distressing disorder, and although they are not likely to take life, migraines can destroy the quality of life. Studies have shown the incidence of migraine to be in the range of 9 to 10%, and it affects 17% of the female population and 6% of the male population. So, about 2 million Australians can expect to suffer from migraine, and that translates to 1.5 million women and about 500,000 men. It is thought that more women suffer migraine than men due to hormonal factors. There are several types of migraine, the two main types being classical migraine and common migraine. Classical migraines are preceded by an aura, the duration of which varies between 15 minutes up to almost an hour. The headache usually lasts 6 to 8 hours, although they can last up to 72 hours. Common migraines are not preceded by an aura, and the headache lasts between 4 and 72 hours and can be pulsating and unilateral. An upset stomach and vomiting are common symptoms. Migraines can be divided into a number of distinct phases. The first phase includes the early warning symptoms. A significant number of migraine sufferers experience warning symptoms for up to 24 hours before the attacks start, but may not recognize these signs unless they know what to look for. The common symptoms include changes in mood, and these moods can vary from elation, such as feeling on top of the world and full of energy, to opposite moods, such as feeling depressed and irritable. There are several abdominal symptoms common to migraine, including nausea, changes in appetite, such as intense hunger or sugar craving, constipation, and diarrhea. Neurological changes may also occur prior to the migraine, including drowsiness, incessant yawning, symptoms of dysphagia, such as difficulty in finding the right words, a reaction to excessive brightness or sound, and difficulty in eye focus. There may also be changes in behavior, such as hyperactivity, clumsiness, or lethargy. And many sufferers report muscular symptoms, such as general aches and pains. The second phase is the aura. The aura accompanies migraine attacks in about 20 to 30% of migraine sufferers. The most common aura symptoms are visual disturbances, such as bright, zigzag lines and flashing lights. As well as that, there may be difficulty in focusing or blind spots. The aura commonly affects only one eye, but it can disturb the visual field of both eyes. It usually lasts between 5 and 60 minutes, then the vision normally returns to normal. Less commonly, aura affects sensation or speech. The third phase is the headache. The headache phase can last for up to 3 days. It is often throbbing and on one side of the head, but it can affect both, and it is made worse by any kind of movement. The most common accompanying symptoms in this phase are sensitivity to light, sound, and smell. Eating can help reduce symptoms, especially starchy foods such as breads and pastas. The symptoms can be more distressing than the headache itself. The final recovery stage may last for about 24 hours, and feelings range from complete lethargy to feelings of high energy and even euphoria. Sleep often is beneficial for adults, while effective medication can improve attacks for chronic sufferers. Children seem to feel much better after vomiting, and for a few, nothing works except the headache burning itself out. The dietary triggers include alcohol, especially red wine, certain types of food, notably aged cheese or chocolate, withdrawal from caffeine or caffeinated drinks such as coffee and tea, the food additive monosodium glutamate, dehydration, and inadequate meals. Environmental triggers include bright sunlight, flickering lights, strong smells, for example, perfume, gasoline, chemicals, smoke-filled rooms, and certain food odours. Another environmental trigger is high altitudes or flying. Weather changes can be a trigger factor, as can loud noises or overuse or incorrect use of computers. Other trigger factors include the hormonal triggers. Hormonal fluctuations are implicated as a significant trigger for women, as 3 times as many women suffer from migraine headaches as men. This difference being most apparent during the reproductive years. The hormonal triggers may be menstruation, and a UK study found that 50% of women are more likely to have migraine around menstruation, ovulation, use of oral contraceptives, pregnancy, and it may be worse for the first few months, but in 2/3 of women it improves in the latter part. Hormone replacement therapy and menopause.
That is the end of Part C. You now have 2 minutes to check your answers.